Hello everyone. Today we are going to discuss about the anesthetic management in supratentorial tumor surgeries. I am Dr. Dheeraj Masapu from Sakra World Hospital. I have no actual or potential conflict of interest in relation to this program or presentations. I will be showing some of the drugs and products, but I am not endorsing any of those. So just for the visual understanding, I'm showing them. So this presentation goes in this direction. First, I'll be discussing the basic anatomy, then types of tumors, and a little bit of statistics, and preoperative evaluation of the patients, intraoperative goals, and tumors in the eloquent cortex, emergence and extubation concerns, and the recent trends. So this presentation will be more of the practical aspects of dealing supratentorial tumor surgical anesthesia. So this presentation, I would like to discuss two case scenarios. The one is a middle-aged man. You can see in the first image, he's come with a right frontal lesion, and his GCS is little drowsy, and he's opening eyes only to deep painful stimuli. And the second scenario is a fully preserved patient with normal neurological function, and he is having a small tumor near the motor cortex. So my presentation will be going in this direction of explaining these two case scenarios. So let us discuss some basic anatomy. So the supratentorial compartment is called supratentorial because it is above tentorium cerebelli. It is a layer of dura which separates supratentorial compartment to infratentorial compartment. And why supratentorial compartment is important is because most of the body's important functions are located in the supratentorial compartment, like motor function, speech, and your vision in the occipital lobe. So now let us see what are the different types of tumors. There are over 120 types of tumors in the brain. The most common ones are listed in the slide. And for anesthesiologist purposes, you can just take it as gliomas, meningiomas, and pituitary tumors. So gliomas constitute around 30% of the tumors, and meningiomas constitute around 35 to 40% of the tumors, and the rest of them are pituitaries and some CNS lymphomas. So this is WHO grading of tumors. So why we should know this grading is higher the grade, there is more possibility of neurological damage and more possibility of intraoperative brain bulge and more possibility of intraoperative bleeding. So that is why we should know the grade of the tumor as well. Coming to some Indian statistics, the incidence of central nervous system tumors in India ranges from 5 to 10 per 100,000 population, and the trend is increasing. And they account for 2% of the malignancies. And the median age of tumors was seen to be at least a decade earlier to the Western population. The reason being Indian population is a younger generation, so that is the reason. And among the tumors, astrocytomas constitute to nearly 40%, and the majority of them being high-grade gliomas, around 60%. So if a patient comes for a preoperative evaluation, so what you need to do, apart from your general anesthetic examination, you also need to see his neurological examination. You need to assess his mental status, motor, sensory, cranial nerves, and cerebellar functions. So why we do this is you need to differentiate a new deficit which is happening after the surgery with an already existing deficit. So you should also see patients' signs and symptoms for high ICP situation like nausea, vomiting, drowsiness also should be seen. So let us go to the first scenario. First scenario is a large tumor with a lot of perilesional edema located in the right frontal area. And this situation, the patient is a little drowsy also. So as you can see in the graph, you are seeing this is a graph which is actually showing a Munro-Kelly hypothesis. It says that when a volume of one part of the brain is expanding, the other compartments try to compensate to a particular extent, but after a particular extent, they cannot compensate. So your patient is already in a steeper part of the curve. So a slight increase in the intracranial volume by increasing the blood flow, cerebral blood flow, he is going to have a dramatic increase in the ICP. So these kind of patients are more prone for intraoperative brain bulge situation. And the next situation you are seeing in the image, 26% of the tumors are located in the frontal area, and the left frontal area you have the Broca's area, and that is where your speech is actually articulated. So this kind of tumors, you are concerned about preserving the speech. So here the anesthetic concerns and management would be totally different. And same as well as with the motor cortex tumors, the tumors which are on the motor strip, So when these patients, actually your concern is to preserve the motor function during the surgery. Let us see how we are going to do that. So if this patient comes for a pre-anesthetic checkup, what you are going to talk to him is very important, which decides the course of the surgery. So you need to explain him so what is awake craniotomy and how we are going to prevent his deficits during the surgery. And you should make him understand about the procedure by showing him, if possible, videos of the previous patients. And you should also explain how the OT environment will be and how the tables and sounds will be, and explain him what kind of issues he is going to face. And you also need to explain what kind of mapping you are going to do on him, speech mapping or motor mapping. Parallelly, you should also assess his psychology, whether he can withstand the awake craniotomy. So if he is fitting, then you can take for mappings. So let us see what medications these patients will be on. Usually, these patients will be on antiepileptics. American Society of Neurosurgery, they recommend usage of antiepileptics in the perioperative period in supratentorial tumor surgeries. So you can continue them in the perioperative period. They will be on a dose of steroids also. You might have to continue them. And preoperatively, because of the usage of steroids, you need to check their blood glucose levels, because higher glucose levels are detrimental to the brain function. And because of the usage of diuretics like mannitol, there can be fluctuations in the electrolyte levels. So you need to see the electrolyte levels also preoperatively. So after the preoperative evaluation, let us go to the intraoperative goals and management in scenario 1, that is the right frontal big lesion with perilesional edema. So here what you need to understand is autoregulation of the brain. So autoregulation of the brain is the capacity of the brain to control the blood flow at a particular level of blood pressures. So, but unfortunately, the studies are showing that if the midline shift is more than 5 millimeters, autoregulation of the brain will not be functional. So the brain becomes more pressure passive. And if in that kind of patient, if you are going to increase his blood pressure, there will be increase in the cerebral blood flow, hyperemia, and brain can bulge in the intraoperative period. On the opposite side, if you're decreasing the blood pressure, you can go into ischemia. So you need to control the blood pressure in a very optimal level in this kind of patients. And one more thing is blood loss. So, and high-grade lesions are very prone for bleeding. So you need to reserve packed cells and check hemoglobin at periodic levels during the surgery. And during induction, any induction agent is fine, because propofol and thiopentone, both of them will decrease the cerebral blood flow and decrease the intracranial pressure. But the most important thing is during intubation, you need to prevent the intubator response, because any kind of sympathetic stimulation can lead to hyperemia in the brain. So you can use either pharmacological agents, or cutting down the time of direct laryngoscopy also will help during induction of anesthesia. And you can also use arterial line monitoring if you're anticipating bleeding in this particular case. And most of the stimulation will also be there during the pin application time. And during that time, you need to increase the depth of anesthesia, or you can give a dose of esmolol or other beta blockers during that time. And in our center, we give scalp blocks after induction. So that will take care during the pin application, as well as during periosteal dissection. Even during that time, there will be a lot of sympathetic stimulation. So the scalp blocks will take care of that situation also. So coming to maintenance of anesthesia, in this particular case, volatile anesthetics are known to increase the cerebral blood flow and intracranial pressure. And theoretically, brain bulge can increase with volatile anesthetics. And on the other side, total intravenous anesthesia with propofol decreases the cerebral blood flow and intracranial pressure. So theoretically, you can have a lax brain. So what are studies showing? The brain bulge situation between a total intravenous anesthesia with inhalational anesthesia. And in the first study, they found that the number of patients having tensed brain in inhalation group is high. And in the second study, also showed the same thing with a significant p-value. The number of patients with brain bulge is more in the volatile anesthetic group. So based on these two studies, I can suggest you to use total intravenous anesthesia in this particular kind of patients during the surgical maintenance of anesthesia. And this is if you want to do inhalation only. And between the drugs, most commonly used nowadays are desflurane and sevoflurane. And in between the two drugs, there is no difference, significant difference between the dural tension, even before and even after opening the dura. So any drug is okay. A small mention about nitrous oxide. Nitrous oxide theoretically increases the cerebral blood flow and can increase the brain bulge during the surgery. Not only that, it has some other problems also while usage. It's like most of the patients, some of the patients develop pneumocephalus after the surgery. So if you're using nitrous oxide in that particular patient, there is a possibility that it can get converted to tension pneumocephalus. And one more thing is, if you're planning for electrophysiology in that particular patient for mapping purposes, the nitrous oxide can interfere with those. So based on this, I would suggest to avoid nitrous oxide in tumor surgeries. Coming to antiedema measures, the 3% saline and mannitol are commonly used, and I would take a call based on the patient's condition. If the patient is hypovolemic and if I want to replace some volume as well, I will go for 3% saline. And if the volume status is fine and his renal function is fine, then maybe I would go for 20% mannitol. But the most important thing is you need to address a brain bulge in a multimodal way rather than targeting only 2 drugs. So it is more like you need to decrease your ATCO2 because your carbon dioxide reactivity will not go. It will be present even in midline shift patients. So decreasing the ATCO2 will decrease the cerebral blood flow and brain bulge will come down. But there is a lower limit, less than a PaCO2 of 25, you should not come down. And along with that, you should take care that the venous drainage is good and adequate, avoid neck flexion. And you should also make sure that the peak lung pressures are not very high. Sometimes secretions in the endotracheal tube will also be there. You need to do an endotracheal suctioning that time. And shifting from inhalation to total intravenous anesthesia is also a good option to deal with brain bulge. If lumbar drain is present, you can actually drain it, but very cautiously. So after the craniotomy, you need to drain, not before that. That is the situation. So summing up everything is called as chemical brain retractor concept. So whatever I explained now is called as chemical brain retractor concept. You need to do that whenever there is a tense brain situation during the surgery. And intravenous fluids, what to use, you don't have to break your head. Any IV fluid is fine. The target is to maintain euvolemia, not the choice. If you keep on using the same 0.9% NS, patient might land up in hyperchloremic acidosis. So it's better to alternate. Or nowadays you're getting balanced solutions which are isoosmolar and exact electrolyte content of the blood. You can maybe use them also. So coming to the emergence times compared within total intravenous anesthesia and sevoflurane, this study found that there is no significant difference between the emergence between volatile group and the TIVA group. And another study which has compared the recovery in obese patients between desflurane and sevoflurane, and practically no difference in the brain bulge between the two. And you can see a significant decreased extubation time in desflurane group. So if given an option, if brain bulge is the same in both the drugs and the extubation time and recovery time is less in desflurane, I would choose desflurane. And coming to extubation, whom to extubate, whom not to extubate is mainly determined by the preoperative GCS of the patient. If the patient is very drowsy and if is not obeying commands, then better go for a postoperative ventilation in those patients. And if the patient is conscious and obeying, then you can plan to extubate on table. And unstable hemodynamics requiring very large inotropic supports, maybe you need to go for an postoperative ventilation. Other patients, you can go for extubation. So in the extubation, the most important thing you need to see is muscle relaxant effect should not be there. Inadequate reversal is not acceptable in neurosurgical emergence. So that will lead to a lot of tachycardia and hypertension, can lead to formation of intracranial hematoma. So you need to have a fourth twitch in the TOF. And also timing is very important for extubation. You need to give some time. You need to suction the patient in depth, and you should not keep on stimulating the patient. So you need to wait for the patient to get up on his own. At the time of extubation, maybe you can use agents like esmolol, short-acting ones, or labetalol. These are the initial agents of choice. Nitroglycerin should be the last resort because theoretically it will increase the cerebral blood flow and increase the intracranial pressure. So I would suggest keep nitroglycerin as a rescue for the last. Don't use it in the beginning. So what is my technique? My technique is no-touch extubation. So what I do is, once the case is over, I do suctioning in deep, keep the patient, I won't touch him, till the patient opens his eyes. Maybe I'll waste another 5 to 10 minutes, that's all. So after 5 to 10 minutes, once the patient opens his eyes spontaneously, then I would extubate him. In this way, I have actually seen the hemodynamics are under control. There is no way that inadequate reversal can happen, and the complication rate is very less in this technique. You can see 3 graphs. The hemodynamics are better controlled in no-touch extubation technique. So let us go to the next scenario where the tumor is present near the eloquent cortex. So in this particular situation, either we need to do either speech mapping or motor mapping. So both of them actually need awake craniotomy. So speech mapping needs to be done under awake, but for motor mapping, there is an option. You can actually do under general anesthesia also, but you'll get only 40 to 50% of the times. So in motor mapping, what we do is we do cortical mapping, we do subcortical mapping also. So if you're doing under general anesthesia, the first thing you should do is you should avoid muscle relaxant. Maybe intubating dose can be given, but after that you should not give. And you need to maintain the patient on total intravenous anesthesia, preferably target control infusion of propofol at around between 2 to 3 micrograms per ml. And you can supplement that by using fentanyl, remifentanil, and dexmedetomidine to cut down the dose of propofol usage. BIS monitoring is mandatory because if you go too much deep and you don't get electrophysiological signals in mapping. So that is about the general anesthesia. And for mapping for Broca's area and Wernicke's area, you need to do awake craniotomy. For Broca's area, what we do is called a speech arrest. We keep the patient awake, we'll tell him to count the numbers, we stimulate the area, and there will be a sudden blockade in his counting numbers. So that is called a speech arrest. And Wernicke's area, he needs to understand a situation and a scenario. He needs to explain that. So to do all these things, you need to do awake craniotomy. For that, how we do is we give scalp blocks of all the major nerves. Supraorbital, supratrochlear, greater occipital, lesser occipital, auriculotemporal nerves will be blocked. You can use either bupivacaine or bupivacaine. Both of them are good. And what technique that you need to do is asleep, awake, asleep technique, or awake, awake, awake technique. And so in asleep, awake, asleep technique, there is a small problem. So you will be sedating the patient in the initial part of the surgery till the dural opening. Then you'll wake him up. Some patients will become delirious during that part of the, when they get up from anesthesia. In awake, 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 we just keep the patient comfortable throughout the procedure, and we'll make sure he's not having pain, and we'll be continuously talking to the patient. In this kind of anesthesia, there is no risk of delirium. And what drugs to use for sedating a patient in awake? In India, most commonly dexmedetomidine has been used. The reason for that is dexmed has a very good profile of not losing the airway, and also dexmedetomidine simulates natural sleep. So when patient comes out of dexmedetomidine, the chance of delirium is very less. Propofol and remifentanil combination is also used in several parts of the world. So both the techniques can be tried, but the main point is patient should be awake and comfortable at the time of mapping. That is the final point. So a study compared between dexmedetomidine and propofol and remifentanil in awake craniotomy. They observed that there was no difference between the groups in respect to mapping, but the respiratory events are more in the propofol remifentanil group. So point to be noted. So then coming to how useful is awake craniotomy. Awake craniotomy, a study is done comparing craniotomy under GA, and they have seen the extent of resection of tumors near the eloquent cortex, and they found that the tumor extent of resection is more in awake craniotomy group than under general anesthesia and mapping. So in that way, a better survival will be present. So let us see what are the recent trends in the management of supratentorial tumors. This is called as photodynamic diagnosis. In the image you are seeing a red color. The red color is the high-grade lesion. The surrounding is a normal brain structure. So for a normal human eye, you cannot differentiate to the extent of what photodynamic diagnosis will do. So what you need to do is you need to administer 5-amino levulinic acid 2 hours prior to the surgery. And the patient should be kept away from sunlight for nearly 24 hours because there is a risk of photodermatitis. And as an anesthetist, you should know that hemoglobin and platelet counts can decrease by administering 5 ALA. But I got a study which is done on 207 cases between 2008 to 13. They did not find any kind of skin reaction, and they did not find any kind of hemoglobin or platelet count drop during administering 5 ALA. So it is a very safe drug to administer. And the next advance is ultrasound and resection. Ultrasound actually helps you to localize the tumor and to know the extent of resection, and to know the vasculature in a vascular tumor. You can put Doppler and see whether it is an artery or a vein. So it will give you a lot of information. But the neurosurgeons are not very familiar with the ultrasound. So as an anesthetist, if you can help them to facilitate the surgery, and it will be very useful for the outcome of the patient. And the next is intraoperative MRI, and a lot of centers are now starting intraoperative MRI. So the anesthetic relevance is a lot of points are there here. Like you need to use MRI compatible equipment, and you need to have a separate cable system so that eddy currents are not generated, and you need to protect the fingertips and everything from burns. So it's a big topic, but you need to have knowledge about intraoperative MRI as well, because studies are showing that the 37% secondary gross total resection is seen. That is like 37% of the time the neurosurgeon is actually deciding to re-explore the lesion. So when people understand the importance, lot and lot centers will start getting intraoperative MRI. And the next concept is daycare supratentorial neurosurgery. So patient will get admitted on the morning and will go in the evening. So this is a study which has done in Canada in 198 patients, and what they observed is 88.4% of the times they did not have any problem discharging the patient on the same day. Only 1.8% of the patients actually developed intracranial bleed. So this is one more thing. Out of the 198 patients, almost 157 patients underwent awake craniotomy. So awake craniotomy forms the major element in same-day discharge. And the next thing is improving the oncological outcomes. In future, more and more studies are coming up how anesthetics actually impact the oncological outcome. So this study is actually compared volatile and TIVA in comparing the outcome in solid tumors. What they observed is volatile and inhalation anesthesia was associated with a hazard ratio of 1.59 compared to TIVA. So this study is showing that TIVA is better, but we cannot come to conclusion. But in future, the research will be going in this direction as well. And coming to the final point, the pain management. So considering the postoperative pain management in brain tumor surgeries, you cannot use opioids because they will actually interfere with your GCS monitoring. You cannot use NSAIDs because there is 1.1% chance of intracranial hematoma formation. So you're actually left with very few drugs. So what we suggest is approach it in a multimodal way. Preoperatively, you can administer drugs like gabapentin, and tablets also you can give. So they will actually cut down the requirement of analgesics in the intra and postoperative period. And also intraoperatively, you can use paracetamol. Paracetamol cannot be a sole agent, but it will be a part of multimodal program. And as I told, NSAIDs cannot be used. And in the postoperative period, you can administer actually, one more thing is in the intraoperative period, scalp blocks are very helpful. So what we are doing is we are giving before and after also. If you can supplement a dose of scalp block at the end of surgery, then that will take care of his pain for nearly 6 to 8 hours in the postoperative period. That is one more useful thing that you can do. And sometimes the dressing that we put for the head can be also very tight. So releasing that also will release some pain. So in a multimodal way, you need to think in all the directions, and you should be patient-centric. And so in that way, you can decrease the pain in the patient. So the topics that I covered in this particular presentation is I discussed a scenario of glioblastoma multiforme, and also I discussed about the tumors which are present near the motor cortex, and I explained the recent trends and pain management in supratentorial tumor surgeries. Thank you very much.